Welcome to the GLP-1 RA series from the American Heart Association, sharing insights on the heart and kidney health benefits of GLP-1 receptor agonists. This series is supported by an educational grant from Novo Nordisk. CE and ABIM MOC credits available.
Welcome to Heartbeats from Lifelong Learning and our series GLP-1 receptor agonist, what you need to know. Today we will discuss individual drugs and practical aspects, including the forms of administration, pens, issue with oral forms of the medications. And this is one of a series of the American Heart Association supported by Novo Nordisk. After this podcast, we hope that you'll be better able to identify approved GLP-1 receptor agonists to manage type 2 diabetes, articulate the mechanism of action of GLP-1 receptor agonist, the medication dosing, an appropriate mode of administration of these medications. To summarize the glycemic effect of this medication as well as the extra glycemic benefits, and finally, to appraise the safety profile of the GLP-1 receptor agonist currently available on the market in the US. I'm looking forward to our discussion today about individual drugs and the practical aspects of their use. And I'm going to start by introducing myself. I'm Justin Shufo, and I am a physician and also a scientist. I'm based at Johns Hopkins University, where I'm an associate professor of medicine at the Division of Endocrinology, and I'm also going to hand over to Dr. Jennifer Trujillo, who's going to introduce herself.
Thanks, Justin. I'm happy to be here with you today. I am a professor at the University of Colorado, Skaggs School of Pharmacy in Denver, Colorado. I'm also a clinical pharmacist and a certified diabetes care and education specialist at the University of Colorado Endocrinology and Diabetes Clinic. Our disclosures are shown on the next slide. And I'd just like to jump right in. Justin, could you start us off and give us a high-level overview of the incretin system? What's the role of the incretin gut hormones, such as GLP-1, in normal glucose homeostasis? And how do the GLP-1 receptor agonists work to lower glucose?
Thank you, Jen, for this very important question. And that will allow me to set the stage for our discussion today. Talking about the mechanism of action of the GLP-1 receptor agonist, as you can imagine, these drugs act by mimicking the effect of the endogenous glucose-like peptide 1, which is normally released by the L cells in the intestine in response to food ingestion. And once released, the GLP-1 will act on several organs or tissues across the body. And as you could see on the slide here, there are many sites of action of the GLP-1 and by extension of the medications. The main sites on which the action results in the lowering of the glycemia includes the pancreas, where GLP-1 will promote the proliferation of beta cell, and the result of that is an increase in the synthesis of insulin and an increase in the release of insulin, which leads to the lowering of glycemia. Another effect on the pancreas is the counteraction on the effect of glucagon, which is a hyperglycemic hormone, as you know. The other sites on which the action of GLP-1 results in a glycemic lowering effect is the muscle, where it promotes insulin sensitivity, which leads to an increase in the glucose uptake. The glucose is removed from the circulation, which results in a lower sort of circulating glycemia. Another major site of action of the GLP-1 agonist, the GLP-1 itself and the agonist, is the brain, where, as you may know, there are receptors mainly in the hypothalamus, where we have the center for satiety, And the resultant effect of the GLP-1 on the hypothalamus is the decrease in the food intake. As you can imagine or you have experienced in a lot of patients, the administration of those drugs leads to a loss of appetite, and that's the main driver of the weight loss. I have to point out that the main, contrary to the sort of the popular belief that the weight loss medication is related to the effect on the gastric motility, I think the main driver of the weight loss effect is from the central effect. Another major system on which there is a beneficial action of the GLP-1 receptor is the cardiovascular system, where the drugs will act both on the vasculature and also on the heart itself. On the vasculature, it tends to reduce local inflammation, which ultimately reduces the risk of atherosclerosis. And then has an effect on the vessels, by having sort of vasodilatory effect, which leads to a decrease in the blood pressure. In addition, it has a direct effect on the heart by sort of improving or enhancing the contractility of the heart. It also has a natriuretic effect, which affect the hemodynamics and sort of probably also lower the blood pressure. An additional effect that has the sort of cardiovascular benefit is the effect on the liver, where it affects the trafficking of the lipids, resulting not only in reduction of the deposition of fat, the steatosis in the liver. That's why the GI people are sort of loving this drug, because it sort of prevents, at least in the initial study, steatosis and possibly cirrhosis. But the other resultant effect of that, as I was saying, is the improvement of the lipid profile, which ultimately has a sort of cardiovascular benefit. And just to sort of close this chapter on the various sides of action of the medication, I just want to mention the kidney, on which it has a sort of an effect that promotes diuresis and natriuresis, and there is emerging literature suggesting that these drugs may actually prevent the deterioration of the renal function. And briefly, just to mention that, on the gastric musculature, it sort of slows the emptying of the stomach and also the overall gastric motility, which has an implication for people who have gastroparesis, as we will see later in the talk. And in the bone, apparently, it sort of increases the bone formation and the bone mass, but we do not yet have a sort of translation of this in sort of clinical sort of usage for bone therapy. So just to quickly summarize, I just want to say that, the GLP-1 receptors agonists not only, improve glycemia, they have a multitude of other effects that they have because of their pleiotropic action in the various tissues in the body. So, Jennifer, now that sort of I've given us an idea of how these medications work and where they work, can you please elaborate a little bit more on the magnitude of their benefits, both glycemic and non-glycemic?
Sure. It's a great question, and an appropriate question after you think about the mechanism of action. How do all those mechanisms translate to clinical outcomes? I guess I'll start with glucose lowering. These agents have been studied extensively in type 2 diabetes in a wide range of patient populations with a variety of background therapies compared to a variety of comparator agents. And across the board, we know that GLP-1 receptor agonists have very strong glucose lowering effects and the highest amounts of weight loss compared to other diabetes medications. But if you move on beyond just those surrogate markers, you start to look at other things like cardioprotective effects. The GLP-1 receptor agonists appear to have anti-atherosclerotic effects as well. This is a summary of the cardiovascular outcome trials of the GLP-1 receptor agonists. And what these studies have shown is that 3 agents in the class have demonstrated cardiovascular benefits. So liraglutide in the LEADER trial, semaglutide in the SUSTAIN 6 trial, and dulaglutide in the REWIND trial all showed a reduction in major adverse cardiovascular events, which was the primary outcome. That's a composite of non-fatal MI, non-fatal stroke, and cardiovascular death. If we look a little closer at these studies, we can see some particular benefit with some of the secondary outcomes, particularly a reduction in stroke, which kind of highlights the fact that they're very anti-atherosclerotic medications. And while we did not see a reduction in heart failure hospitalizations, there may be some other benefits that we didn't capture in these cardiovascular outcome trials. Finally, I just want to mention, to kind of piggyback on your comments with the mechanism of action related to the kidney, we did see, albeit a secondary outcome, we did see a reduction in worsening nephropathy with these cardiovascular outcome trials as well. So if you put all of this evidence together, I just think it's important to recognize that we're seeing benefits, of course, with glucose lowering, with weight loss. They all have a low hypoglycemia risk, but we're also seeing benefits beyond that. So 3 of those medications, we saw that reduction in cardiovascular outcomes, and we saw some secondary endpoint indicators of reduction in nephropathy as well. So I've mentioned various outcomes with the GLP-1 RAs and that they have clear benefits, but I think there's one outcome that's worth a brief discussion because the effects of GLP-1 RAs on it may vary over time, and that's retinopathy. So Justin, I'm wondering, what are your thoughts about the impact of the GLP-1 RAs on retinopathy complications in people with diabetes?
Yeah, thank you, Jane. That's a great question. It's an interesting question. As you mentioned, the clarity or clarification is sort of needed regarding retinopathy. I think the original trial sort of suggested that the use of GLP-1 receptor agonists may have a detrimental effect in people with diabetes and retinopathy. But over time, with the accruing or accumulating evidence, what we've noticed, and this is based on a recent meta-analysis that included data from more than 90 studies, including various GLP-1 receptor agonist molecules. The sort of overall evidence suggests that in the beginning, at the start of the treatment, especially in those with early stage retinopathy, there may be a transient aggravation. But as patients are using the drug for a longer period of time, what is sort of observed, or what clearly comes out, is an improvement of the retinopathy itself, and more importantly, there's a significant reduction in the risk of progression from early stage retinopathy to late stage retinopathy. And this is even more so than insulin, because in this sort of meta-analysis, there was a comparison between the GLP-1 receptor agonist and insulin, and there was a sort of strong suggestion that the use of GLP-1 receptor agonist will be much more protective in terms of progression from early stage to late stage. The other point, late stage of retinopathy, the other point to mention is that, it emerged that the main molecule that could be sort of thought of as a culprit here is albiglutide, because the worst effect on retinopathy was observed with this drug in particular. And in sensitivity analysis, when this drug was removed from the pool analysis, there was really no adverse effect on retinopathy. So I have to point out that albiglutide is not commercialized in the US, so that's actually good news. With what we know about all the beneficial effect, Jennifer, can you sort of please elaborate a little bit on the place in the hierarchy of the type 2 diabetes medication? In other words, at what point in time in the natural history of type 2 diabetes should these drugs be used?
I think that these agents can really be used at any point in time in the course of a person's diabetes. All of the agents are approved for glucose lowering. And in terms of timing, I think there's really been a big shift in recent years in this regard. you take a look at the American Diabetes Association treatment algorithm, and metformin is no longer the tried and true first-line therapy for all people with diabetes. The guidelines are really recommending and encouraging early use of medications that address some of the diabetes comorbidities. I think they're taking a much more holistic view as opposed to just a very glucose-focused view. So, when you're thinking about the place in therapy for GLP-1 RAs, they are preferred agents along with the SGLT2 inhibitors in people that have established cardiovascular disease, regardless of A1C, regardless of metformin use. And they're also suggested as add-on therapy after SGLT2 inhibitors in people with chronic kidney disease. And then if you've got someone that doesn't have any of those comorbidities, these agents are ranked very high in terms of their glucose lowering effect and their weight loss efficacy. So they're also considered to be preferred agents for those that need just some good glucose and weight loss lowering effects. Finally, I'll just mention too that I think we used to consider insulin to be, a very common go-to once you got to the need for injectable therapy. And the ADA guidelines actually recommend that GLP-1 receptor agonists are the preferred first injectable before insulin in most situations. So that's where I see the place in therapy for GLP-1 receptor agonists. I think they have an important place in the management of type 2 diabetes. But of course, they carry some potential risks that we have to consider as well. So, Justin, I'm wondering if you can let us know what you think the main contraindications and side effects are with these medications.
Yeah, Jen. So that's important because I think the proper use of those medications requires a very good knowledge of when not to use them. So yeah, so a couple of things that one has to consider when prescribing those medication, and as you could see on the slides, I've sort of classified them in two groups: the contraindications and precautions, and then the side effects. In terms of the contraindications, there's some contraindications that are sort of absolute. I would say that, a history of medullary thyroid carcinoma, both personal or familial, is actually an absolute contraindication. The same is true for multiple endocrine neoplasia, 2A or 2B. And here, a personal and family history of this sort of syndrome is an absolute contraindication for the use of a GLP-1 receptor agonist. In MEN, it's even if the patient hasn't sort of developed medullary thyroid carcinoma, the idea is that they are at very high risk of developing a medullary thyroid carcinoma, which is in terms of thyroid cancer is one of the most aggressive form of thyroid cancer. So it's absolutely necessary to stay away from the medication. From these medication in those type of patients. The other contraindication to consider is pancreatitis. If somebody has a history of pancreatitis, it's important to consider not to use the medication because an acute hemorrhagic pancreatitis has been sort of reported with the GLP-1 receptor agonist. And if in the course of the use of the medication somebody develops a pancreatitis, it is wise to sort of stop using the medication. Things that are much less of absolute contraindication or contraindication, but it's just I put it there just to highlight that one should take some precautions when using those medication in those circumstances. And this is type 1 diabetes, and the reason being that we don't have evidence from robust and clinical trials of people with type 1 diabetes. So, and the medications are not FDA approved for use in type 1 diabetes. I know that in practice we may be using the medication in type 1 diabetes, but officially it's not sort of approved for that. The other circumstances in which that require some sort of precaution is renal impairment, especially if the EGFR is less than 30. I would say one should use the medications with caution. Now, in terms of the side effects of the medication, many of you will be familiar with the gastrointestinal side effects, which are the major side effects. It mainly includes nausea, vomiting, and diarrhea. And one way to try and mitigate or minimize those side effects is to start those medications with the lowest dose and sort of increase the dose progressively over an extended period of time in a stepwise manner. That's sort of the traditional way of minimizing those GI side effects. The other side effects of the medications that I already mentioned is pancreatitis. Some people using the medications have also developed a gallbladder disease. It's unclear whether this is causal or not, or an association was observed in some of the series. And then, as with any medication, some of these medications may lead to hypersensitivity reaction, which goes from local reaction to anaphylaxis and angioedema. So one should be able to identify those. And specifically with exenatide, there are two things that have been reported in literature. There's kidney failure reported with exenatide, and there's also thrombocytopenia reported with exenatide. Regarding hypoglycemia, I would say hypoglycemia is not a side effect of this class of medication per se. However, people are susceptible to develop hypoglycemia if these medications are used in combination with insulin or sulfonylurea, which is sort of an insulin secretagogue. These two groups of medications tends to foster hypoglycemia. So hence there's a need to adjust their dose when they're used in combination with GLP-1 receptor agonist. So that's in a nutshell sort of the side effects that are usually observed with this medication. Now, I'm going to say, since we now have a pretty good idea of the mechanism of action of those medications, the extent to which they lower glycemia, and they're also beneficial for weight loss and sort of beneficial in other systems in the body, and we have a pretty good idea of their safety profile and Jen, can you sort of elaborate now on what molecules are out there on the market and sort of what dose for each of those molecules out there, and how to sort of practically use those the medications that are approved, that are FDA approved?
Sure. I think this is such a crucial piece of the puzzle for GLP-1 receptor agonists, because there's quite a bit of evidence that tells us that these agents are still underprescribed. There may be some hesitancy with, which one do I pick? What dose do I pick? There's also evidence showing that the adherence and long-term persistence with these agents can be quite poor. So making sure that providers are prepared to select the most appropriate agent, select the correct dose, understand the titration schedule, all of that is very crucial. And of course, making sure the patients know how to administer the medication properly is key. So there's a lot of differences within the class. First, just thinking about the FDA indication, note that the 3 agents with positive cardiovascular outcome trial data have added FDA indications for the reduction in MACE. Note also that 2 of these agents, liraglutide and semaglutide, have FDA indications specifically for weight loss, but at higher doses and under different brand names. I'll also point out that we do have some higher doses that are now approved for dulaglutide and semaglutide. So they did additional studies after they first came on the market showing that higher doses did have some additional benefit for glucose and weight loss. So we now can go up to 4.5 milligrams for dulaglutide, and we can go up to 2 milligrams for semaglutide. Comparing the administration of the agents, we have 1 agent that's twice daily. That's the first to market exenatide immediate release, which we don't use very much anymore at all. 3 of the agents are daily and 4 of the agents are once weekly. They are all subcutaneous injections except for oral semaglutide. And most of the agents, you need to start at that low dose and titrate the dose up over time as a strategy to decrease those risks of GI side effects. The way in which these medications get prescribed varies depending on the pen device itself. So, for example, subcutaneous semaglutide is available in a titratable multi-use pen device with pen needles included in the prescription. So you don't have to order those separately. The patient dials the pen to the desired dose, and the first dose increase can occur with the same strength pen device because they're using that pen for multiple doses. Alternatively, dulaglutide is available in a fixed dose, single-use pen device. So you use the pen once and you throw it away. And each pen is just one time only. The needle is already attached. So any dose titration requires a new prescription for that next dose. I also wanted to mention the oral agent. We have oral semaglutide. This agent does offer patients an option to not inject, but specific administration is really required to ensure the absorption. So similar to what you might remember with levothyroxine, it must be taken 30 minutes before any food, medication, or other drink, and it should be taken with no more than 4 ounces of water. So very specific. The pill can't be crushed or split. You're not supposed to take it out of the bottle ahead of time. So no pill bottles with oral semaglutide. And if a patient doesn't follow these administration steps, then they might not actually see the result that they're looking for in terms of glucose or weight lowering. Finally, I would be remiss if I didn't mention the cost of these medications. These medications are expensive right now, but they also lower the rates of heart attacks and strokes, which are very costly to the healthcare system. I do think that because of the benefits that we're seeing, I think insurance coverage is certainly improving, but many do require prior authorization for them to get covered. There are some strategies we can think about to help our patients with the cost, including patient assistance programs and prescription drug discount cards and things like that. Maybe we have time for just one more quick question, Justin. What can we expect to see in terms of new medications in the pipeline in this class?
Yeah, that's a great question because there's, as you can imagine, there's a lot of development in this area. And I think just to give you a flavor, I'm going to talk about 2 axes. One is development in improving sort of the oral forms of the medication. As you probably noticed from Jennifer's presentation, the dose of the oral medication is much higher than the dose of the subcutaneous form of the medication. So what is happening is that people are trying to see, for example, for semaglutide, if high doses, 25 or 50 milligrams, are going to amount to more benefits than, the currently highest dose of 14 milligrams. So that's one area of sort of improvement, and one area where we could possibly going to have future formulation or maybe new molecules. The other area is the area of co-agonism, where, as with tirzepatide, which is a GLP-1 GIP dual agonist, they are going to be triple agonist, including obviously a GLP-1 receptor agonist with other type of agonist. An example is GLP-1 agonist, GIP agonist, and glucagon agonist, acting on sort of 3 targets. Another example of co-agonism is, with a combination with molecules that mimic the action of GDF15, for example. So they are molecule under investigations. As you may remember, GDF is sort of, in terms of weight loss, is sort of protective. The same thing with FGF21, for example. So essentially, we're going to witness the emergence of co-agonist medications that includes, in addition to GLP-1 agonist, many other agonists to potentiate the effects of the medication. That's where we're going, essentially. Yeah.
It's really exciting. So many new medications being in phase 2 or phase 3 trials. The next couple of years will be very, very interesting with this class of medications. So I want to thank you for participating in this Heartbeats from Lifelong Learning and our series GLP-1 RAs, What You Need to Know, with us today. We heard a lot of important points about individual drugs and practical aspects, including forms of administration, unique pen characteristics, dosing, and special issues with the oral drug semaglutide. And in closing, I'd like to encourage healthcare providers to consider how they can proactively advocate for and utilize GLP-1 receptor agonists to improve cardiovascular risk factors. To get additional information and to claim credit, please visit learn.heart.org. Thank you and have a great day.